Good afternoon, everyone, and welcome to the National Council for Behavioral Health webinar, Stepping Up the Right Way, Best Practices in the Treatment of Persons with Serious Mental Illness who have had contact with the criminal justice system. Thanks so much for joining us today. My name is Leah Sims, and I serve as a project coordinator with the National Council, and will be serving as your moderator for today's webinar. Also online, we have Chuck and Senior Vice President of Policy and Practice Improvement here at the National Council. Before we begin the webinar, I wanted to note that this webinar is not associated with the Stepping Up initiative, although the titles and topics are similar. This is an independent webinar. Before we dive into the content, I would like to cover a few housekeeping notes. Today's webinar is being recorded, and all participants will be kept in listen-only mode. You can find the call-in number for the webinar on the right-hand side of your screen. Questions may be submitted throughout the webinar by typing questions into the dialog box to the right of your screen and sending it to the organizer. We'll answer as many of your questions as time allows at the end of the webinar during the Q&A session after the speaker has presented. We've also uploaded a PDF version of today's presentation slides, which you can download at any point during today's webinar. If at any point during the webinar you experience technical difficulties, please call tech support at 888-585-9008. We do not want this to be the last time that we interact with you. At the end of this webinar, a brief evaluation survey will pop up on your screen. Please take a few moments to fill out the survey. We will be using these results to improve future webinars and to understand any additional information and training needs you may have related to this topic. I'd like to run through the agenda for today's webinar. First, we'd like to gauge who is actually on the line with two brief polling questions. Next, Chuck will set the stage by giving an overview of the National Council and Novotel telepsychiatry and why it is important to treat people living with behavioral health conditions who have come into contact with the criminal justice system. Next, we will hand it over to Dr. Garvey, who will talk about jail diversion, options for community treatment, the Risk-Need-Responsivity model, and highlight the importance of substance abuse treatment and medication-assisted treatment. After Dr. Garvey has presented, we will address questions from the audience. As a reminder, you can submit questions throughout the presentation by typing them into the Q&A pod within your GoToWebinar window. We'll have our presenter answer as many of your questions as time allows. So now, to help shape the presentation today, we'd like to see who's actually on the line. Please take a moment to answer two brief polling questions that will show on your screen shortly. I will display the polling question number 1, give everyone a few minutes to answer, and then display the results, and then we'll repeat it for poll number 2. So I'm launching poll number 1. So if everyone could take a brief moment to respond and let us know what your profession is. Great. So we've had about 75% of attendees respond. So I'll go ahead and close the poll and share it so everyone else can have an idea of who's on the line. So it looks like about 41% of attendees are psychologists or mental health clinicians, and then 41% are other. So that's interesting. And then we have some healthcare administrators and a few psychiatrists or psychiatric nurses and substance abuse counselors. So now for poll number 2, the last poll. Everyone could take a moment to please answer this poll about whether you are currently working with criminally involved individuals. Great. Thanks, everyone, for responding. So I'm going to go ahead and close the poll. We've had about 75% of people responded. So it looks like, wow, 59% said yes in a community setting, and then 21% said no, and then 19% said yes in a correctional setting. So we have some wide variety across the attendees. So thanks, everyone, for responding to those polls. So without further ado, I'll go ahead and hand it over to Chuck.
Thanks, Leah, and thank all of you for joining us today. I just wanted to provide a brief overview about the National Council. We're a membership association representing about 3,000 organizations that provide mental health and addiction services around the country. We have members in every state, and our role is to try to provide both policy and practice support to those organizations in their community. And one of the areas, obviously, that we're very concerned about is the intersection between mental illness, substance use, and the criminal justice system. The National Council has a number of strategic partners, one of whom is Innovatel Telepsychiatry, who is sponsoring today's webinar. Innovatel Telepsychiatry was founded in 2014 to help address the need for access to psychiatry in community-based settings, particularly in rural areas where sometimes it's difficult to recruit and retain qualified psychiatrists. To learn more about Innovatel and the amazing work they're doing in the field of telepsychiatry, you can visit their website, and the address is there on the slide. You probably we don't need to review too much of this, but obviously this topic of interaction with between mental illness and the criminal justice system is one that's very important and very timely. Research has consistently shown that local jails in the United States touch an estimated 2 million people with serious mental illness each year. Additionally, 3 out of every 4 incarcerated individuals suffer from some substance use disorder. Once incarcerated, individuals with behavioral health conditions tend to stay in jail longer, and they're at a higher risk of returning to their settings after release. Needless to say, it is very important to use evidence-based treatment and other practices that support reintegration, decrease recidivism, and provide the best services to people in all stages of the criminal justice system, including after the release back into the community. And so today we're very happy to be able to present some ideas to you about how to do this effectively. I'd like to introduce our speaker today is Dr. Keelan Garvey. Dr. Garvey is the Director of Forensic Psychiatry at Innovatel. Previously, Dr. Garvey held a number of leadership positions in correctional psychiatry, including as the Deputy Medical Director and the statewide Psychiatric Medical Director for the Massachusetts Partnership for Correctional Health Care, as well as being the Chair of Gender Dysphoria Treatment Committee for the Massachusetts Department of Corrections. Dr. Garvey has presented at a number of national conferences, and without further ado, I'll hand over today's presentation to Dr. Garvey.
Thank you very much, Chuck, for that introduction. Just to provide a little bit more background, I'm very happy to be transitioning into my role as the Director of Forensic Psychiatry with Innovatel, and I'm finishing up my role in Massachusetts as the Chief Psychiatrist for the prison system. So I'm going to focus, I have a few different topics here, but I'm going to spend the most time talking about the reentry period and factors that contribute to recidivism and what we can do to affect change on these factors. I'm going to talk about some other topics more broadly, including jail diversion, because I'd like to just cover at least briefly the places where mental health and the criminal justice system intersect and we have opportunities to make changes. So I'm going to talk about the 2 different types. Probably there are a lot of people on the phone that work in jail diversion and are very familiar with the models that are used, but just want to provide a little bit of an overview and talk about the different types and the evidence that we have to support each one. So we'll go to the next slide. So jail diversion is broadly defined as interventions that aim at preventing criminal recidivism in the seriously mentally ill. And this covers a wide variety of programs in different settings. It includes mental health court, specialty types of probation and parole that are geared towards mentally ill individuals, pretrial diversion I'll talk more about, and then conditional release programs as well. Most of the jail diversion programs have some kind of legal leverage that contributes to treatment adherence. We'll go to the next slide. So when we talk about pre-booking jail diversion, we're looking at the intersection when there's a call to the police for an individual who has committed a behavior that could potentially be a criminal charge or is heading in that direction. Pre-booking jail diversion kind of addresses those kinds of things through various methods. So I'm going to run through 3 basic models of pre-booking jail diversion. So this is prior to any criminal charge or formal arrest. So we'll go to the next slide. So police crisis intervention teams are one method of providing pre-booking jail diversion, and this involves specially trained police officers and enhanced policies in place for working with mentally ill individuals in crisis. There's a national training program on the CIT model that was created by the University of Memphis in conjunction with NEMI and police agencies. And this training includes verbal de-escalation techniques and role-playing exercises geared towards police staff so that they can become accustomed to responding to mentally ill individuals in crisis. In some studies, this model has been shown to be used more frequently by frontline officers than the other models I'm going to talk about, and also to have resulted in fewer arrests than the others. But I'll just briefly talk about several other models. Go to the next slide. So the next type is a police-based special mental health response program. So this is also called the co-responder model. And this involves a clinician that's working with the police department. Often they'd have a clinician respond with the police to a mental health crisis. We can also do it by telephone consultation, so there might be someone on call to the police to help them figure out where to direct an individual that's having a crisis. We'll go to the next slide. And then the last general category, probably a lot of you are familiar with, this is the community-based mobile crisis team that involves mental health clinicians as the primary responders. They might be responding to a request from officers, but they're really kind of frontline responding to the mental health crisis. So we'll go to the next slide, and we'll talk about some of the post-booking models for jail diversion. So post-booking means that the person has committed an act that has resulted in a criminal charge, and this is a method of identifying the correct placement and treatment for that individual. So these can be based in the jail, they can be based in any regular court, or they can be based out of specialized mental health courts. So for jail-based post-booking diversion, specialized personnel, mental health personnel, are working at the jail who identify, assess, and divert mentally ill from custody to community-based treatment centers. This is done with the consent of the prosecutor, judge, and defense attorney, so everyone kind of working together to identify what treatment-focused alternative there is to custody. In a court-based system, a court clinician would conduct an assessment of the individual and develop a treatment plan that involves a bail release. And again, this, of course, involves collaboration with the prosecutor, the judge, and defense attorney, who have to kind of all be on the same page about the determination that this is indicated. In this type of model, the charges are typically not dropped, they're often continued, and that's sort of a mode of legal leverage to ensure treatment adherence. Or alternatively, the person might be given a sentence of probation with special treatment that's also sort of, contingent on their adherence to the treatment. So this type of model can happen in any court and does not necessarily have to happen in a mental health court. Mental health courts have also been developed specifically for this purpose, and they involve judges and prosecutors and defense attorneys that have special training in working with mental health staff to set up the individual with treatment. In these kinds of settings, community-based treatment is mandated and adherence is monitored, but generally the enrollment is voluntary. Mental health courts have a significant amount of variability from state to state and even jurisdiction to jurisdiction in terms of what kind of charges they see. Some of them deal with only misdemeanors, others include felonies as well. They vary in terms of who reports the adherence, so some of them have the probation officers monitoring adherence, and others, mental health providers, are monitoring this and reporting it to correctional or criminal justice professionals. They also differ in the type of sanction that they use. So we'll go to the next slide. So mental health professionals can play a role in any of the systems that I've described above, so they can, and probably a lot of you on this webinar do participate in this kind of role. So you can respond, participate in the co-responder model along with police staff, or provide telephone consultation to police departments. Many mental health professionals work on mobile treatment teams to respond to crises directly. You can be working at the emergency department to evaluate someone that has been brought in by police to help determine whether a criminal justice direction is indicated or they should be directed more towards treatment. In a jail setting, a psychiatric or mental health evaluation is indicated to determine appropriate formats for treatment and what should be initiated. Also, obviously, a risk assessment would be very important in that kind of a setting. And the courts, the mental health clinician might be asked to provide an opinion about suitability for diversion. So this can get a little bit tricky because it sort of amounts to a quasi-forensic role where you might be not necessarily doing a criminal responsibility evaluation in full, but sort of determining whether the behavior involved in the committing of the act was truly due to mental illness and not due to other factors. So for mental health professionals that don't have a lot of experience with that type of evaluation, it's always good to consult with someone who does. If you're lucky enough to have a forensic psychiatrist or psychologist on site in the courts to consult to, or who's doing the evaluation, that's great. You can always use telecommunication as well. So we'll go to the next slide. So the outcomes for jail diversion have not been as positive as I think one would hope. There was a study in 2009 in the Journal of the American Academy of Psychiatry and the Law that found that there wasn't an overwhelming amount of evidence in a review of studies that this intervention does decrease criminal activity. So for the pre-booking jail diversion, the best evidence was seen for that first model that I talked about, the police-based specialized police response model, and that was shown to decrease total time in custody, although not decrease recidivism per se. For the jail-based interventions, the best effects were seen for low-level misdemeanors, and they showed some moderate reductions in arrests, but not really an overall decrease in criminal activity. For court-based jail diversion programs, they were shown to possibly reduce the length and prevalence of incarceration, but not the incidence or prevalence of recidivism. So overall, the individuals were spending less time in custody, but not necessarily committing fewer acts. And there were a variety of potential explanations for these outcomes not being as good as we would hope. One being that there's a lot of diversity in programs, not a lot of standardization. So we're kind of not always comparing apples to apples when we study these programs. And not a big body of randomized controlled trials. So the scientific rigor in some of the studies was not as strong as we might like to see to really support it as an evidence-based practice. So certainly there's a lot of room for, there's a lot of effort being put into this type of program, and certainly well-intended, and there are programs that have been very successful. But more work is needed to really determine what kind of factors should be standard and how these should be studied. So with that, I'll move on to talking about reentry and recidivism. So my interest in recidivism and reentry really came from the inside. So most of my career has been spent inside the prison, so treating individuals with mental illness in a prison setting and a jail setting. And I've had the luxury of, I've been in Massachusetts for a while, so I've had some patients that I've had for a number of years, and I've gotten to see them come in and then leave, and some that I still have. And I have developed a very strong interest in what happens to them once they release. There are a lot of factors that we can control in prison, and I know there's a lot of variability from one state to another and even from prison to prison in terms of what life is like inside the prison. But there are certain things that, one of the things I really enjoy about correctional work is that we don't lose anybody to follow-up, so that's a good advantage. So even people that are a little bit resistant to treatment, either due to a major mental illness or due to a more minor mental illness, but some just resistance to change, we know where they are, and we find them and kind of and stick with the treatment, and we get to see a lot of good results from it. So I really have become very interested in what happens once they release to the community, and there's not that level of oversight. And obviously there's a high percentage of people that get lost to follow-up. To go to the next slide, the recidivism statistics are pretty grim. Probably everyone on this is pretty familiar with this. But this slide is from a chart is from a Bureau of Justice Statistics report that was released in 2013. And this studied and followed all of the inmates released from prison in 2005. So it was over 400,000 inmates, which is pretty average. Usually around 400 to 600,000 are released per year. And in the first 3 years after release, 67.8% were arrested. So that was based on data from 30 states that provided the data. The number in parentheses, the number that actually returned to prison, is based on 23 states of data. So not all of that 67.8% were incarcerated, but 49.7% were incarcerated within 3 years. And then looking out 5 years, 76.6% were arrested within 5 years of release, and 55.1% total returned to prison. So that's 3/4 of people that are being released from prison that are arrested again within 5 years, which is very disheartening. And I think it's probably a lot of the reason that a lot of you are on this call, because I think everyone is probably committed to doing something about this and has been working on that for a long time. Also, it's important to note, too, that the risk per year goes down. So the highest risk is in that first year after release from prison, and with 1/3 of the arrests happening in the first 6 months and half of them happening within the first year after release. So the graph there, that might be hard to see the numbers, but you'll see how each bar represents the percentage of the remaining released prisoners who are incarcerated. So the first year is the highest number in the 40%. Year 2 means that's 28.5% of the remaining people who are not already rearrested. So you'll see that it's a pretty nice steady decrease there from year to year. So highest risk definitely is in the first year and first 2 years after release. So we'll go to the next slide. So looking at those numbers, you can probably understand where the idea came that nothing works. And probably a lot of you are familiar with this history. So Robert Martinson was a sociologist who was asked to study the impact of rehabilitation efforts on the correctional population. And he released a study in 1974 called The Effectiveness of Correctional Treatment, a survey of treatment evaluation studies. So it looked at all the available studies to date and determined that there really was no impact on recidivism. So collectively, all these rehabilitative efforts had not had an impact on recidivism. Later on in his career, he kind of softened that view and emphasized some of the differences between the programs and the lack of consistent scientific rigor in the studies. But the damage was kind of done. And the unfortunate effect of this was that it sort of rationalized the cutting of a lot of programming. So there was a shift at that time away from rehabilitative efforts and towards a greater emphasis on punishment and incapacitation. So if you can't treat them, you can at least keep them away from society and punish them for what they did. And unfortunately, this like I mentioned, failed to take into account the intensity and the integrity of the treatment programs and just lumps them all together. But one positive effect of this was that it led researchers to pay more attention to the quality of studies and the consistency of outcome measures in formulating these conclusions. So go to the next slide. So over the last 40 years or so, there have been many different strategies that have been used to help people that are criminal justice involved decrease their involvement in the system. So we've collected a pretty healthy list of things that we know don't work. I'm going to spend most of the time talking about what has been shown to work, but these are probably things that people are somewhat familiar with, and I think it's important to note that these are interventions that have not proven to be as effective as we would have liked. So the fear tactics that came out a couple of decades ago, probably most of you are familiar with the Scared Straight program, where they take at-risk youth and bring them into a correctional setting and have usually the scariest looking inmates talk to them in a very aggressive manner and try to scare them away from a life in prison. Shock probation is kind of a similar thing, giving people who might be just entering the system brief periods of incarceration to sort of scare them away from it. And unfortunately, this hasn't proven to decrease those individuals' later involvement in the criminal justice system. and in some populations it's actually increased their involvement. So another thing that we know doesn't work, back from the 70s, just relying on punishment and surveillance, that has not proven to be more effective than treatment. And this is something I think it's important for us as mental health professionals, especially dealing with this population who can be very challenging. Talk therapy and other kinds of non-directive client-centered approaches have not been proven to be effective in decreasing recidivism. I think there's a lot, when you work with inmates and the same population out in the community, they have a lot of stress. They have a lot of stress in their lives. They have a lot of stress outside of their lives. And if you, not all of them, but many, if you let them just kind of direct the session, they will vent their frustrations and stress, and require a pretty significant amount of redirection to really focus on doing types of therapy that are actually going to result in some change. So there's definitely a need to avoid that kind of talk therapy venting session, as hasn't been proven to be effective for many people, in particular for the criminal justice involved. Drug and alcohol education alone, so without behavioral and cognitive behavioral strategies, has not been proven to be effective. So their initiative has unfortunately not produced the results that we would have liked to have seen. So we'll go to the next slide. So I know most of us are interested most highly in the seriously mentally ill and how they come into contact with the criminal justice system and how we can prevent this. And I think all of us know this first point: mental illness is not, in general, is not associated with criminality. We all know most mentally ill people don't commit crimes, and most crimes are not committed by the mentally ill. But I think this Peterson study in 2014 is pretty interesting to note, that even among people that we know have a serious mental illness, only 18% of their crimes were actually found to be directly motivated by mental illness. So where does that leave us? So that means, even in the mentally ill, we can't blame this all on their mental illness or on inadequate treatment of their mental illness. That's obviously very important, to adequately treat their mental illness, but we just have to be aware that there's more than that. We can't just treat their mental illness. And several studies have shown that the major predictors of recidivism were actually the same for mentally disordered individuals as they were for the non-mentally disordered individuals. And I'm going to spend a lot of time talking about these factors. And overwhelmingly, these criminal factors have actually been more highly associated with criminal behavior than the actual clinical factors, even among the seriously mentally ill. So we'll go to the next slide. So having said that, I'm going to speak briefly about several different treatment models for criminally involved, seriously mentally ill. I'm not going to go into a lot of detail about each one, but I think it's important to note different interventions that have been done and what data is available and what's not available. So we'll go to the next slide. So first I'm going to talk about assertive community treatment. Probably a lot of you are involved in this treatment. This involves multidisciplinary treatment teams that provide medication management, medication administration, often a nurse going to the home of an individual who's involved and helping them with their medication, mental health and substance abuse counseling, case management, social support, so support for housing, sometimes financial planning support. And this has been found to be effective in some outcomes for the non-criminal justice involved, including there was a meta-analysis in 2007. 6 of the studies looked at were randomized controlled trials and showed that this ACT treatment did reduce homelessness. Unfortunately, the studies that have been done looking at the criminal justice population has not had as much of an impact. It's been shown to have little effect on the rates of arrest and incarceration. There was a meta-analysis in 2001 that showed that 70% of the studies available at that time showed no effect on the rate of arrest and jail placement, and 10% actually worsened. So not great results there. So we'll go to the next slide. And some of these shortcomings are what led to the development of the forensic assertive community treatment. So this involves assertive community treatment and the components of that also incorporates elements that are aimed at preventing recidivism. The data, there's definitely a need for more data. This is still a relatively new, though something that probably a lot of you are involved in, but just not a good body of randomized controlled trials to demonstrate the effectiveness. And studies that have been done have shown that, in general, this form of treatment is very heterogeneous, so not a lot of standardization across states and across programs. And they vary in pretty important ways, including the point of contact, including being placed in a jail diversion, in mental health centers, as part of probation and part of reentry, so anywhere in the process. The staffing also differs. There are some that are more heavily staffed with correctional officers and correctional professionals, and others that are more mental health staff driven. And some of them collaborate with probation officers, but not all of them do. But there's definitely a need for more data. I am going to talk about one specific program in Rochester in a couple slides. So we'll move to the next one. So assisted outpatient treatment, I think probably most of you are familiar with this concept. I know it's a fairly controversial topic, and there are a lot of different opinions about it. So I'm not going to go into all of the ins and outs, but just to give an overview, it refers to a civil legal proceeding that allows the judge to order an individual with serious mental illness to follow a court-ordered treatment plan. And the specifics vary by state, but they typically involve a demonstrated pattern of non-adherence to treatment. You have to meet the criteria for the assisted outpatient treatment, and the criteria are fairly strict in most states. The overall goal is to improve treatment access and adherence to treatment, and there is some form of assisted outpatient treatment, though it's very variable in terms of the program and also what the statute allows, and even more importantly, how it's enforced or whether it's enforced. But 46 states in the District of Columbia do have some form of assisted outpatient treatment. The exceptions are Massachusetts, Connecticut, Maryland, and Tennessee. So I'll just present both sides. The assisted outpatient treatment supporters base their support on the principle of beneficence, and they believe in this treatment as a way of preventing further decompensation and actually allowing for individuals to live in a less restrictive environment. So the belief is that if you continue people on their medication and use some form of legal leverage to do so, that they will be cycling less frequently in and out of emergency room settings and in and out of the hospital, and overall be allowed to live in a less restrictive environment. I think most supporters of this recognize that this is not a substitute for good treatment, so it's really only effective if it's associated with adequate community resources. Doesn't make sense to use a court order to keep someone in treatment when the treatment isn't there in the first place. So go on to the next slide. Opponents of assisted outpatient treatment believe it's unethical to force treatment. This is forced treatment for non-emergency conditions, so they distinguish that from situations where it is an emergency, like an emergency room setting for an acutely agitated patient. They believe it violates autonomy and self-determination. The assisted outpatient treatment term is not universally accepted. It's seen by some as sort of a euphemism, and that the term involuntary outpatient commitment is more appropriate. Opponents also point out, and rightfully so, there are many systems where assisted outpatient statutes are in place, but there really are there's no method of enforcing it. So it's sort of an ineffective intervention. And some believe that it diverts funds away from voluntary service recipients who might be statistically more likely to benefit from the treatment than someone who's opposing the treatment. So looking at the outcomes for assisted outpatient, there's a randomized controlled trial on a North Carolina population in 2001. This was a one-year study, used 331 participants with serious mental illness who were involved in the assisted outpatient treatment. For the whole population studied, there was not a significant difference in the number of arrests or in the number of arrests in that one-year study. But for a subgroup of individuals who have a history of multiple hospitalizations and prior arrests and plus-minus violent behavior, there was a significant difference in the one-year arrest rate, with 47% of the control group being arrested within 1 year in that 1 year that was studied, and 12% of the extended outpatient commitment. It's important to note that that extended piece is very significant. They studied treatment less than 6 months and did not find that same effect size. So the extended outpatient commitment refers to outpatient commitment that lasts for more than 6 months. So this seems like a specific population of patients, but this is really kind of who we're talking about now. Our criminal justice involved, seriously mentally ill, tend to have a history of multiple hospitalizations and prior arrests and often violent behavior. So for this group, this appears to have been beneficial. There was also a discussion that this may have accounted for patients whose arrests are associated with illness relapse may have had the most significant benefit versus the patients that have serious mental illness whose crimes were not really related to their illness and are more related to criminogenic factors that I'm going to talk about. So this study by Gilbert in 2010, this was not a randomized controlled trial, but it looked at assisted outpatient treatments in the New York system and found a 2/3 lower odds of arrest for assisted outpatient recipients. Now the comparison group, this was not randomized, but they were compared to both no assisted outpatient treatment and then this alternative voluntary service agreement. So with a voluntary service agreement, the individual would sign this in lieu of an assisted outpatient treatment program. So it was sort of signed with the threat of assisted outpatient treatment if not signed. These two groups received the same close oversight, the same intensive care services as assisted outpatient, and the voluntary service agreement group did not show a statistically significant difference in the odds of arrest. So the conclusion was drawn that this lack of improvement, even though the treatment and oversight was the same, that court order added an additional benefit, and there may have been some extra motivation to avoid the negative consequences of violating that court order. So going on to the next slide. So the APA did release a position statement on assisted outpatient treatment in 2016, concluding that it is ethical when used appropriately and can be effective as long as there are adequate resources in place that involves intensive individualized outpatient treatment and must last at least 6 months or 180 days. They looked at the outcomes and found them to be positive only under these conditions with systematic implementation and availability of intensive community-based services of adequate duration. So go to the next slide. So the Rochester FACT model, this was just released, the study in June, so last month. And this was a forensic assertive community treatment model that was specifically developed to address the lack of consistent findings and address the variability in the FACT program structure, operations, and the treatment populations. So this was the first randomized controlled trial of a standardized FACT intervention. And one of the significant differences between this and other programs that use FACT were that it did use legal leverage. So it's akin to the assisted outpatient treatment model, and it used the legal leverage to promote engagement. Another difference is that they used high fidelity acts. So the fidelity term is used. That means that they stuck to the strict evidence-based model of using ACT. They identified and targeted these criminogenic risk factors. I've mentioned these a couple of times. I am going to get to them, but this is a very important component of what we're assessing in this population and should be targeting. And they used a strong mental health and criminal justice collaboration that was consistent. So moving on to the next slide. So the results of this Rochester FACT model showed a decrease in criminal convictions, days in jail, and use of inpatient psychiatric services. There was no significant difference in ED visits, although it was noted that there was one individual who accounted for most of the ED visits. So if you remove that outlier, there would be a significant difference in ED visits. But this is significant that there was no change in arrests or incarcerations. However, a third of those incarcerations were due to the imposing of the judicial sanctions for noncompliance. So it didn't decrease the number of arrests or incarceration, but the total time spent in jail and the number of convictions did decrease. So as you can see from that third number, that some of the incarcerations were brief and were for the purpose of carrying out those sanctions, which I think a lot of supporters of assisted outpatient treatment might be in support of, but those who are not, who are opposed to it, might raise issue with the idea of incarcerating someone for noncompliance. But just wanted to present that evidence. That's a relatively new study. So I'm going to spend a lot of time now talking about the idea of what works, and this means what works for reducing recidivism. There's not really a clear, easy answer, but there have been a number of interventions that have been proven to be more effective. The risk-need-responsivity approach I'm going to spend some time talking about, and this is kind of one of the most important models for addressing this population. Other things that have been proven true are that treatment does work better than punishment. Behavioral interventions have been effective, but much more strongly cognitive behavioral therapy interventions, which I will speak about more specifically, have been effective. And this probably goes without saying, but well-designed and well-implemented programs are most effective. So there are a number of programs that have been designed well, but if there's not a lot of oversight or standardization over the staffing, they might not be implemented as well. So we'll go to the next slide. So this, I'll just explain the risk-need-responsivity model. So in this model, the risk is not risk in the sense that we usually think about. It's not looking at the risk of harm to self or others. In this model, risk really refers to the who. So, and this is the idea of matching the level of intervention to the risk level. So high-risk offenders need high level of intervention. So again, the risk level is the risk of recidivism. So that seems kind of obvious, but I think maybe less obvious is that several studies have shown that if you take individuals who are identified as lower risk for recidivism and put them in these high risk, high intensity interventions, that they can actually do worse. So it actually may increase their recidivism rate. And there's a few explanations for that. There's some thought that it's the influence of the higher risk individuals that they might come into contact with, who sort of teach them bad behaviors and bad habits. So moving on to the needs. The need is what? So the what that needs to be addressed is the criminogenic needs. So we really want to change the negative behavior, and to do that we have to focus on these criminogenic needs that I'll talk more about that are met by that behavior. So you have to kind of get to the root of not just what the behavior is, but what is triggering this behavior. And then the responsivity refers to the how. And general responsivity means the how has what's been most proven to be effective is social learning interventions, cognitive interventions, and most importantly CBT. Specifically, the way that those are applied to the individual takes into account the personality factors and personal strengths of each individual. So I've talked a lot about the criminogenic risk factors. I'm just going to go through these briefly, and then I'm going to talk about each one in more detail. The first three kind of go together, but are still kind of distinct concepts: antisocial behavior, antisocial personality, antisocial cognition. It's not a surprise that those would result in recidivism and criminal activity. Others include criminal companions. I'll spend some time talking about. Substance abuse is an obvious source of a great deal of criminal activity. Family and marital problems, and then work and school problems. It's kind of a cycle. They contribute to criminal activity, but criminal activity also worsens those kinds of social issues. So helping people to get out of that cycle is very important. And this one, the last one, I think is something that we sort of ignore in a lot of settings: the lack of healthy leisure and recreational activities. It's easy to do when you're focusing on someone who's an active substance abuser and they have sort of bigger fish to fry in the treatment. But I think paying attention to what alternatives they have to criminal activity and what kind of drives their need to be involved in criminal activity is very important. So we'll go to the next slide. So I mentioned the risk and evaluating who's the person that needs the intervention, low risk versus high risk. There are over 60 instruments that can be used to assess a person's level of risk. These risk needs assessments measure the offender's criminal risk factors that, if addressed, will lead to decrease in recidivism. So I listed the most commonly used assessment tools. But overall, in general, they collect data through an interview process where they get a lot of data about behaviors and attitudes, and then they supplement that with historical information like arrest and criminal records. And these assessment tools can be used in sentencing, but many are often used to identify treatment needs as well, and to match criminal justice involved individuals with appropriate programs and services. Most use both static and dynamic risk factors. Static, of course, are the ones that don't change. So if you have a history of committing a violent crime, you will always have that history. So that would be a static risk factor. The ones that are really targeted by these interventions are the dynamic risk factors, or the modifiable risk factors. In general, these show moderate accuracy in predicting risk. If you're going to use them, you just have to make sure that you're familiar with the population that was used to validate them, and using them in a setting for which they were designed or have been modified for. They also often differ in how recidivism is defined, so just make sure that you're familiar with how they're defining their outcomes. We'll go to the next slide. Just briefly, this is actually something used by probation, this EPICS model. It was designed by researchers at the University of Cincinnati. It's called Effective Practices in Community Supervision. And this effectively translates that risk-need-responsivity into practice for criminal justice professionals. So teaches probation officers to use social learning theory and CBT methods. And some find it very helpful. Others in the criminal justice side have found it too prescriptive. But it's something probably some of you are familiar with. And I'm going to talk next, when we go to the next slide, I'm going to spend some time talking about what we as mental health professionals can do and should do to address these risk factors. So the first three, I'll talk about the problem and the needs, and then I'll talk about some potential ways of addressing these. So antisocial behavior, I think we're probably all familiar with this. So indicators are an individual with early and ongoing involvement in criminal acts in a variety of settings. So a lot of my patients that I've had on the inside of prison have a history of DYS, and juvenile records and multiple arrests and incarcerations. And their needs and what they need from us is to help them identify high-risk situations that typically result in those kinds of criminal acts, and help them develop alternative pro-social behaviors in those high-risk situations. Also, obviously important would be, learning to recognize what a high-risk situation looks like and potentially avoid it. So moving on to the next factor, antisocial personality often goes along with antisocial behavior. Indicators include impulsivity, aggression, thrill-seeking, kind of a hedonistic way of living, pleasure-seeking, and a lot of irritability. And these are individuals that we've probably all treated in every setting, frequently come to the ER. We definitely see them a lot in the correctional setting. But most of them have not developed a really strong mechanisms for coping with strong emotions or with perceived injustices or external stressors. So they really are in strong need of anger management, coping skills, self-regulation skills, problem-solving skills. And the next antisocial criminogenic risk factor refers to antisocial cognitions. So this is an important thing to keep in mind when you're treating this population, because many of our individuals in the prisons and in the jails and then that enter the community are coming from environments where they were taught that rules and the law and authority figures are bad. So they may have grown up in a very violent neighborhood. They may have grown up in a family that had gang involvement. But there's this inherent belief among a lot of them that authority is bad, and that they won't be able to succeed in a conventional way, that they're not going to be able to follow the rules and have any sort of success. A lot of times they also lack empathy for others. So these are challenging thoughts to overcome, and this is not something that can be done in one session, and there are a number of tools that can be used, but you really want to try to help them develop, change those cognitive distortions. So practice less risky thoughts and challenge their distortions about externalizing blame. We see this a lot in the prison setting where they get a ticket for something and they may admit that they had some kind of property that they weren't supposed to have, but it's somebody else's fault because it wasn't, somebody else has it too and they didn't get a ticket for it. So a lot of externalization of blame, a lot of rationalizing of criminal behavior, and just this overall rejection of authority. These are very common thought distortions. And again, this is just as significant in the seriously mentally ill as the non-mentally ill. So to address all that antisocial traits of the personality, behavior, and cognition, there are a number of cognitive behavioral strategies and programs that have been developed specifically for this population. So I've listed some of the most studied and most widely used, including thinking for a change. That's one that I've had experience with in the prison setting. Aggression replacement therapy. This one's kind of a mouthful, but criminal conduct and substance abuse treatment strategies for self-improvement and change. Moral recognition therapy, reasoning and rehabilitation, and relapse prevention therapy. And probably most of you have come into contact with at least one or more of these. And these strategies are designed for use in correctional settings and community settings with criminal justice populations. They're designed for use by both criminal justice staff, so to be used by parole and probation with the appropriate training, and mental health professionals. And this focuses very heavily on cognitive distortions and like the ones that we discussed before about rationalizing crime and kind of rejecting authority and believing that they cannot succeed in a, in the legal world, in the legal realm. So these programs vary in terms of their content, but they're often pretty structured. We have specific schedules for each day and specific homework assignments, and they teach skills that are needed to make pro-social choices and teach and help develop coping skills. Of course, developing coping skills, I'm sure everyone is aware, is a very challenging process for a lot of them. But many of them are able to effectively identify coping skills that are much more adaptive and healthy than the ones that they were using previously. There's a CDATE project, CDATE, that's an acronym, that did a meta-analysis of the effects of various interventions and found that CBT models like the ones that I've listed are much more effective than just the behavioral techniques. And the behavioral techniques refer to things like a token reward system or specific sanctions. So really gets to the importance of not just addressing the behavior and training the behavior, but also getting to the underlying thought behind the behavior. We'll go to the next slide. So moving on, another important criminogenic risk factor to consider is the presence of criminal companions. This is a really challenging factor that it's more complicated than people who haven't worked with this population might think, because unfortunately it's not as simple as telling them to make new friends. And this is something I spend a lot of time talking with my patients about as they're getting ready to go out, because they often don't have an ideal placement to go to, and they have to make a decision that involves either going to a shelter where they know that there might be some criminal activity and possibly drug use, or going to live with a family member who's actively involved in drug use or criminal activity. So some of them, many of them don't know anybody that don't engage in antisocial activity and don't use drugs. So it's a really hard decision for them to make to kind of bypass their family members and their friends who want to help them when they have very few resources themselves. You'll see people in the prison setting that denounce their gang affiliations, and sometimes that results in the need for protective custody. And that comes out as they're approaching release, because of course there's no protective custody on the street. So many of them are worried about their safety. So they may have made a healthy choice to avoid their criminal companions inside, but then that results in some danger to them on the outside that's just sort of undeniable. So what we can do to help with this, we can really try to help increase their desire to avoid antisocial peers. You can use motivational interviewing. A lot of them do have this desire, but the practical aspects of avoiding everyone they know on the outside are just very challenging. We can also help them to become involved in activities that might involve pro-social peer groups. I think it's hard for most adults to develop new hobbies, whether you're coming out of prison or not, and make new friends. And not surprisingly, people who are not involved in the criminal justice world often don't want to associate with people who are coming out of prison. So it's a difficult thing for them to get out and avoid the people they knew before and make new contacts. It's very challenging. It's something that definitely is very extensively discussed for a lot of inmates as they're releasing, but really a very important component of their treatment when they get out. We need to recognize that they might be surrounded by people that are really influencing them. Substance abuse, I think everyone on the call is probably very familiar with the association of substance abuse and criminal activity. Obvious indicators are alcohol and drug use, but also we see a lot of people in the prison setting and the jail setting that have committed substance-related crimes besides just, drug possession, robberies, armed robberies, violent crimes while intoxicated. And these individuals, which amounts to about, depending on what statistic you use, about 75 to 80% of the prison population need substance abuse treatment programs. So for individuals in the community, this involves acute detoxification. For people coming out of prison that might have served a lengthy sentence, this can be more complicated. A lot of them do go to residential placements. But I think it's important to note there are some very excellent residential placements, but there are others where, and probably a lot of you have seen this, but there are a lot of residential placements that have pretty heavy drug use. I've had patients tell me that they were on the staff at residential treatment programs in the past and using substances with their clients. So I think we can't discount the fact that a residential placement, as well as a prison and a jail setting, does not prevent them from using drugs. In prison setting, if you survey everyone incarcerated at any given time, statistically you'll find about 10% that have positive tox screens for some substance. So there's a fair amount of substance use that does happen in prisons. Some of the better prisons, correctionally speaking, are able to keep things out for the most part, and you can see a significant difference in individuals who might have served a lengthy sentence and been able to be sober the entire time. And obviously this is not an ideal way of resulting in long-term sobriety, but it's very interesting to see the difference in them from when they come in to several years later when they haven't used any substances. Medication-assisted treatment, I'm not going to spend a lot of time talking about. It's a very important topic, but in the interest of time, the National Council website, in case you haven't seen it yet, but they have a lot of excellent resources and links on this topic, including some webinars focused specifically on medication-assisted treatment. Medication-assisted treatment is a pretty broad term and refers to substance abuse interventions that combine behavioral therapies and medication. So this is not a new concept. These medications have been around for a long time. There's more attention and focus and hopefully more resources being put into this because of the attention to the opioid epidemic. But some options include methadone and buprenorphine, and then naltrexone and the long-acting injectable form of naltrexone, which is Vivitrol. One thing to note from inside prison, buprenorphine is a very effective medication for harm reduction. We do see a fair amount of abuse of this medication in the prison setting and probably the jail setting too, which probably has a lot to do with the fact that it's something that's easy to get in through the mail because of the formulation that it comes in. But it's definitely not without abuse potential, which probably everyone is aware of, but just something to be aware of. So go to the next slide. In Massachusetts, where I've worked for the last 7 years, we started this our participation in the MATRI program, which is Medication-Assisted Treatment Reentry Initiative. And it's a prison-based treatment program that starts on the prison and continues into the community. So the people eligible for this program, they have to meet certain criteria, but it's a pretty broad brush that we use to determine who's a potential candidate. So we have in the prison setting, when we say residential placement, for prison that refers to therapeutic communities. In Massachusetts, it's called the Correctional Recovery Academy. So those individuals that are completing that program would be eligible, but we also have a lot more inmates that are involved in non-residential substance abuse treatment programs that are provided by different organizations, so that many of them would also be eligible. One of the best parts of the program is that it involves a recovery support navigator that meets with the person on the inside, but also follows them on the outside. It might not be the same person, but they help them, help to find them if they get lost, to follow up, and help to encourage them to continue to go for their injections. Unfortunately, I don't have data on this program yet where the outcomes Outcomes data is going to be analyzed at the 3-year mark, so we expect to see that in September. It started in August of 2014. And while we're on the subject of substance abuse, I think it's important to talk about the prescription drug abuse that happens in prison. So everyone's familiar with abuse of opioids, benzodiazepines, and stimulants. But there are several medications that, if you don't work in prison settings, you might not be aware are widely abused. I think it's starting to become more of common knowledge, but bupropion, gabapentin, and quetiapine are very widely abused in the correctional setting. When I first started in corrections, I kind of assumed that that was because that was what they could get, and once they get out to the street and could get harder drugs, that they would have less interest in that. But I think, after having worked in the system for longer, and I've seen people come back into the system who reported that they continued to abuse these drugs on the outside, I think you just have to be aware of the potential for that, and that they may seem like benign requests, but I've seen individuals coming into the system that actually have injected these medications. I have people that have injected bupropion, so just worth noting and being aware of. So moving on to the next criminogenic risk factor. So family and marital problems are very common in a correctional population, especially among the seriously mentally ill in corrections. There's a lot of marital conflict and partner conflict, and a lot of them didn't have great modeling for parenting. I mean, some of them did. Not everyone imprisoned, had poor parenting, but it's pretty common that they had, negligent or abusive parents or substance abusing parents. So they didn't really learn the way to kind of model discipline for their children. So the way to address this would be family therapy. It's just sometimes done on the inside, particularly with female populations, with younger infants. There's some family work involved, but certainly on the outside, it's a big adjustment when they're coming out of prison, and their families are excited to have them. But I think understanding what they've been through while incarcerated, and for them, they're just trying to navigate getting their license and getting a driver's, a car and a job and all that stuff. And it's hard for the families to really understand that they're not just going to be able to jump right back into work or, what they were doing before, or that they need to start over and do something completely different. So you want to help them develop these appropriate parenting skills, which you can do on the inside. Many of our inmates do have regular contact with their family and play a significant role in raising their children, even from the inside, as challenging as it is. So the next criminogenic risk factor that's important to take into account is the high prevalence of work and school problems. So indicators are poor performance in school and high dropout rates. I see most of the patients I see on the inside of the prison setting are not high school graduates. It probably depends on the prison setting, but overwhelmingly, they've dropped out of school. There's a lack of consistent employment. They've had a long string of disciplinary problems at work. I think it's also important to note that a lot of them have reported that they've never really enjoyed a job. They've never had a legal job that they've enjoyed doing. So to help them with this is something that's often helped with some of the work release or pre-release programs that allow for work in the community while they're still in custody. But you really want to help them identify the strengths that they have, whether it's manual labor or computers or some kind of skill that they may have picked up on the inside. You really want to identify these strengths and also identify the deficits they have and what accommodations might be available. It's important to recognize, too, that even if they have the skills and the brain power or the physical ability, that a lot of people that are cycling in and out of the prison system don't have the social skills for work. So they don't know how to respond appropriately to supervision. They don't know how to manage conflict. So you can do some role playing with that to help them navigate those essential components of being an employee. Just briefly, there's a program called the Reintegration of Ex-Offenders Program. Some of you might be familiar with. This started in 2005, and it is an employment-focused reentry program. So it contains mentoring, employment services, case management, and unfortunately, the 3-year impact study showed that it had no effect on recidivism. So the idea was that maybe not enough resources were devoted to the other sources of recidivism. So again, remembering that there are 8 criminogenic risk factors that have been most highly associated with recidivism. And focusing all of the energy on one, and I don't think this program focused exclusively on that, but that was the primary focus, is not likely to result in significant change. And that leads us back to the importance of doing the proper assessment, both clinically and using the risk assessment tools to identify which specific needs each individual has, and targeting a treatment to those, and recognizing that there are going to be different components of the treatment that are indicated based on those specific risk factors that they have. So there might have been, inadequate substance abuse treatment, or focusing so heavily on work. There's a very high percentage of inmates that have a lot of physical problems. That a lot of them have reckless lifestyles, and lots of orthopedic injuries and accidents and head injuries and things like that that might make it difficult to work. Housing is obviously essential as well. There's also something called the maturation hypothesis. So this is the idea that you can't take someone who has these antisocial cognitions and kind of rejection of authority and give them we know that jobs are a significant challenge for people when they're getting out, but it can't just be the job. We have to be working on changing the obstacles that have been in place for them that have prevented them from having successful jobs in the past. So we can't just give them the job and hope that that solves their other social problems. We have to be doing more than that and addressing the reasons that jobs have been challenging for them in the past. The last criminogenic risk factor, I think, like I mentioned before, I think this is really overlooked sometimes. It's a really important thing to consider for people that are releasing from prison and newly released. A lot of them really never developed, either because of the type of neighborhood they grew up in, or lack of parental involvement, or early involvement in gang activity. But a lot of them never developed non-criminal leisure activities. So not surprisingly, former inmates and probationers who reported fewer recreational activities are more likely to recidivate. So what can we do? This is challenging. This is something that a lot of us spend a lot of time talking with our inmates about when they're getting ready to release, and soon after release as well, because you can't discount the importance of recreation and of occupying empty time. Obviously, the more time they have that's unstructured, the more time they have to get into some of their old habits. So we can use it. It's challenging. I think when you work with them inside, you often do this to try to help them participate in some of the activities that are available. There are many that would rather watch TV and not really do much, but there are, depending on the prison setting that you work in or the jail, there might be some structured recreational or sports activities. So you can use motivational interviewing. You can teach skills needed for involvement in these activities, like playing chess or music. A lot of people that are incarcerated have a musical background or develop musical skills once they're inside, and those are the kinds of things that really need to be fostered. We also have to take into account that a lot of people that are mentally ill and cycle through the criminal justice world have that sort of hedonistic, pleasure-seeking, risk-taking personality that's not likely to change, and we have to help them translate that into something that's legal and hopefully less dangerous. There are plenty of legal but still kind of risky hobbies that people can get into, and I think we can't discount the fact that there are many individuals that need something to replace that. We can't just tell them not to do it because they'll find some way to fill that risk need. Unfortunately, I couldn't find any outcome studies that showed benefit for change or plans to change recreational patterns. So I think that's something that definitely needs further study and discussion. So in all of this, all the strategies that we can use as mental health professionals, one thing that's completely essential when you're dealing with recently released inmates or individuals who have been diverted from the criminal justice world is that we really have to have good collaboration between criminal justice and mental health. And this is sort of something that goes without saying, but I think the specifics of this are sometimes overlooked. So if you survey patients or inmates about what information might be shared, say between their probation officer and their mental health professional, they tend to either grossly overestimate and believe that we tell them everything, or completely underestimate and think that everything is confidential. So we have to be and this is going to vary according to the rules of probation and the system that you're in, but we have to make sure that if we're treating people who are parole involved or probation involved, that we have to understand what needs to be reported and when, and we definitely have to communicate that to our patients as well, because nothing hurts rapport like telling your probation officer something that they thought was going to be confidential. So mental health and criminal justice, we obviously come from different backgrounds, but need to work together and demonstrate to the patients that we share the motivation to keep them out of a custody setting. And we can do this and avoid splitting by having joint meetings with correctional or criminal justice staff and mental health staff to help build that therapeutic alliance. And one thing I found, Lamberti wrote this in 2016, but this idea of being firm, fair, and caring, I think this is just a really good, succinct summary of what it takes to work with this population, because many of them are very good at testing boundaries. I think we all have to be aware that we are at risk of having boundaries crossed. Even if you think you have very good boundaries, there are very sophisticated criminal justice involved individuals who will challenge that. So we have to be firm. I think the fairness really comes down to consistency. They need to know if I do this, this is going to be the response. And we have to be firm and fair and consistent with our response. But we also have to show them that we're not just there to keep them in line or report to their probation officer. We have to show them that we're actually invested in working with them to keep them out, and that we actually care about their success. And our reasons for being firm and fair are that we believe that this is what's best for them. So just very quickly, probably some of you work in settings that are funded by some of these federal grants, but if you're interested in looking at reentry funding opportunities, there's the Second Chance Act of 2008 that provides federal funding for reentry programs, and state and federal agencies and nonprofits and Native American tribes can apply for these. If you're interested, the grant money changes from fiscal year to fiscal year, so the Department of Justice website is a good resource to look and see what's available. It's kind of hard to see, but the www.grants.gov is also a good resource. This is just a map showing all the Second Chance Act funded programs, which probably covers some of the programs that you all work in. So just to summarize, mental health professionals can play a role with the criminally involved, seriously mentally ill at any stage, prior to arrest, at the time of arrest, during incarceration, and definitely outside of incarceration once they've been released. We have to remember that the mental illness is essential to treat, but it's not the only thing that needs treatment. We really need to take into account these criminogenic risk factors and recognize that it's not, for most individuals, at most times, it's not the mental illness that's actually driving the criminogenic behavior. And we really have to focus on targeting them, addressing them, and working with the patients to modify those risk factors. We need to have very good collaboration between mental health and criminal justice professionals. And I think this is a conclusion for a lot of talks, but we definitely have a need for more standardization of these programs and more kind of scientifically rigorous research to demonstrate that these programs are effective, which is important for our own knowledge, but also for funding purposes as well. So with that, I'll thank everyone for listening, and we have about 15 minutes, so we'll open up the floor for questioning. Thank you.
Thank you, Dr. Garvey. And before we move ahead to the question and answer portion of today's webinar, I wanted to bring your attention to two additional resources. The first is Mental Health First Aid, which is an 8-hour course that teaches people how to identify, understand, and respond to signs of mental illnesses and substance use disorders. Mental Health First Aid has trained over 1 million people, including teachers, police officers, firemen, and women, correctional officers, veterans, and government officials. There are specific trainings for public safety, crisis intervention teams, and youth and adolescents. To find out more or become a Mental Health First Aid trainer, visit the Mental Health First Aid website listed on the screen. The second resource is the International Association of Chiefs of Police One Mind campaign. IACP is the largest law enforcement membership organization in the world with over 25,000 members in 115 countries. IACP's One Mind pledge asks chiefs of police and other law enforcement members in leadership positions to create a partnership with community mental health organizations, implement a policy within their bureau to respond to persons affected by mental illness, train all staff in mental health first aid, and provide crisis intervention team training to officers. Whether you are a direct service provider involved in the criminal justice system, these are both great resources for your organization or to share with your community partners. So now, before we move into the question and answer portion of the webinar, I want to remind everyone that the recording for this webinar and the slides will be available on the National Council website within 48 hours. We've also gotten a lot of questions about downloading the slides, and you can download the slides at any time during this webinar on the right-hand side of your screen in the handouts pane. With that, we are ready to move into the question and answer portion. So please go ahead. We already have some questions in the queue, but if you have a question, feel free to type that into the Q&A pod. Our first question for Dr. Garvey is, how does one determine whether crimes are driven by serious mental illness or by criminogenic risk factors?
That's an excellent question. I think that gets into sort of the forensic evaluation and the importance of consulting with a forensically trained person. But so when you're doing, that's ultimately the question that's asked if you're doing a criminal responsibility evaluation or not guilty by reason of insanity evaluation. But you have to look at, to do it less formally in a treatment setting, you're looking at if you have an individual who assaulted someone, so whether this happens in the community or it happens in prison, it's really important to interview them, obviously, and get a sense of what their version of events are. So there have been times I've had patients that got into a fight, and my first thought was, to look and see if they've been compliant because they have a psychotic diagnosis. I see they've been compliant with the medication. And then I kind of go and see them and evaluate them and expect to find them decompensated. But there have been times when they had a very clear reason, like this person, took something out of my cell, and I did what I had to do. So that's where you get into the fact that most seriously mentally ill in the criminal justice system still have these other factors. So they may have a serious mental illness, but they also have these kind of antisocial cognitions and kind of need for retaliation and sort of, the other things that drive violence in the non-mentally ill. So I think it's important to get collateral information. You might hear from people that witnessed the event that, so-and-so walked up to this other person and just hit them seemingly out of nowhere. They had no conversation before. So you look at all the collateral information to describe the event. Or you might hear that they've been arguing over the last couple of days. It sort of escalated. If there's a clear reason for the crime that appears to be more rational in nature, though not a good choice, that it's less likely to be driven by mental illness. If it's sort of seemingly random and unprovoked, it could be substance related, but it could be a function of mental illness also. You definitely want to ask them about any kind of delusional beliefs, or if they commit some kind of crime that's sort of in line with their chronic delusional beliefs, and that's important information. But it's difficult to do as a treatment provider. It's kind of a different role when you're a forensic evaluator and you're not treating them. But it is an important skill set to have. But you really want to look at all the information around the event to determine what caused it, what the person's version of events is, and whether it seems kind of rational and maybe more antisocial, or it seems delusional or more consistent with their mental illness.
Great. Thank you, Dr. Garvey. So the next question is about trauma-informed services. So this person asks, I am surprised that you made no mention of trauma or trauma-informed services. I'm especially curious about the considerations of Bethel Vander Kolk's work, and I'm aware of use of high-risk inmates with very interesting positive results while still incarcerated. Are you able to speak to trauma-informed services?
Oh, sorry. Yes, can you just repeat that because I missed part of it? You cut out a little bit, or I cut out.
Yeah, of course. Sorry about that. So this person is asking about trauma-informed services, and they're especially curious about the considerations of Bessel van der Kolk's work and the use with high-risk inmates, where positive results have been shown.
I think more generally about trauma-informed approaches, both in community or in correctional settings, and have you had any experience with those?
Okay, yes, yeah, sorry, I didn't, there were a lot of topics that I wanted to get into more, but in the interest of time, I didn't include. The trauma-informed care is part of a lot of the training programs, because obviously understanding the basis of and the social effects of the trauma and the high prevalence of people that are involved in mental health services and the criminal justice world is very important to understanding how to manage them. I think it's a big part of our work with correctional staff and with criminal justice staff as well, is helping them to understand that as well, and work towards less physical means of managing behavior. But I really didn't get into that, just in the interest of time and kind of focusing on other topics. But definitely is it a very important topic and probably would warrant further discussion.
Great, thank you. So the next question is, how would you recommend bridging the gap between the differing perspectives that criminal justice professionals and mental health professionals have regarding this population?
Yeah, that's a great question. And this, I think, varies a lot. I've worked in about 4 different state systems and see a significant difference in how mental health is received by correctional officers. And again, most of my experience in that has been on the inside. And I think communication, it sounds kind of cliche, but that really is the most essential part of bridging that gap, because they often don't understand where we're coming from, and we don't understand where they're coming from. And the only way to bridge that is to ask. So they might not understand why we, put someone on a mental health watch, or why we send somebody to the hospital that is not, necessarily behaviorally active, but we're worried about their mental illness. So it's just important to maintain those open lines of communication and ask if we don't understand why why the correctional or criminal justice staff or police are behaving a certain way. It might be that they're not familiar with this population, if they need additional training, or they might have experience with that individual and know that some specific intervention worked. So I think just being very open about the differences and recognizing that they are there to serve a different purpose from what we are. But overall, I've been pretty lucky in Massachusetts that the correctional staff has been very supportive of mental health services. I mean, it's not without some challenges, but I think just maintaining that communication is really essential, and asking for clarification when you need it, and if you see opportunities for training, I think it's usually well received, because they often want to know why we make the decisions we make too.
So, Dr. Garvey, this is Chuck Angolia. So I'm just wondering, in response to that question, do you find like using something like a risk needs assessment instrument on the mental health side, does that help in those conversations or in that collaboration with the folks on the other side?
Yeah, I think so. I think we do it sort of more informally, where we talk about if there are patients that are acting in a certain way, we want to inform them about how much is related to mental illness, and then also what other kind of factors might be driving their behavior. So I think the more training that the officers have on that model and on on CBT in particular, that's kind of a challenge, because there's a lot of in lesser experienced and less trained correctional and criminal justice professionals, there's sort of a tendency to give in to things, which really kind of goes against our behavioral and cognitive behavioral approaches, and sort of sets us back a few steps. So definitely kind of explaining the rationale and the theory behind what we do, and having them trained in those types of interventions is helpful.
Great, thanks. So we have a lot of questions, but I think we're running short on time, so we're going to go ahead and wrap up. So let me thank you again, Dr. Garvey, for your time, and we're so grateful for your expertise and willingness to share it with us and with the audience. And also our gratitude to Novotel Telepsychiatry for their continued partnership on initiatives such as this webinar. Finally, thanks to all of you for joining us today. As you exit the webinar, a brief survey will pop up on your screen. Please take a few moments to fill out the survey and give us your feedback. This is an opportunity for us to learn about your needs and identify how we can further improve our webinars. On behalf of the National Council for Behavioral Health, we truly hope that you have found the information provided during today's webinar helpful, and we remain committed to providing quality technical assistance to providers of behavioral health services. Thank you again, and have a wonderful rest of your day.